on target to introduce Professor Ego Seeman, who is in the upper right-hand corner. Ego, do you see us?
I don't see you, but if you see me, that's good enough.
All right. So, Ego, I saw you a bit earlier. I know it's about midnight. I was going to ask you, did you get a haircut?
Kmart.
All right. So, Ego, you don't like introductions either, but Ego is in Melbourne, Australia. It's around midnight. Ego comes to all ASBMR meetings, but for reasons that we won't go into, he wasn't able to come in person. But we convinced him to stay up late tonight, and he's going to talk to us about issues related to bone quality. And what does that mean anyway? He'll take issue even with the word. Just as a comment, and you'll hear from his presentation, Ego is one of the great iconoclasts of our time. And he will emphasize the point that truth is only fleeting and not always necessarily forever. And so I think part of his theme is going to be what we know today may not be known tomorrow. But Ego, it's a great pleasure to have you. We're going to watch you and we're going to hear you. Take it away.
Okay, thanks very much, John. Can you see my slides?
Yes.
Okay, so the first slide, the title slide is up. Is that correct? I just need to know that.
Yes.
Okay. All right. Well, I hope you can hear me okay. Thank you. I'm sorry I can't make it this year. Believe me, I am very sorry that I can't, especially to your meeting, John. John is the sort of mentor's mentor. John is the ultimate physician, and he's so committed to running this mentorship program, and it makes me feel very, very honored to be part of the faculty. And I think it illustrates something that actually John just said, that all of us, I think the whole faculty now, who've been together for a long time, really regard mentorship as being terribly important. And it's precisely because what we know or what we think we know is so fleeting. Whatever we say is usually wrong. It is almost certainly always incomplete. And as new technology arises and new ideas come, those things change. But the thing that doesn't change is what we do in this room that you're in. And that is, if we help you guys in any way to develop your own sense, your own critical sense, then we really have achieved something, I think, that is lasting. We can't do that alone. You have to be and learn to be a participant in your own progress. And so I want to just start my talk by this little thing here, which was found in the Dead Sea Scrolls, and it's written by somebody called Anonymous. And what it is the following: advancement of science, but more important, the advancement of self is captured, I think, here. That only doubt is certain and disbelief worth believing. Without this courage, and it is courage, there can be no learning, believe nothing. You're at a crossroad now, and up to this time approximately, your success is based on your ability to reproduce precisely everything that your teachers tell you. And if you do that, you get first-class honors, you go to the best universities, and you then, some of you, become the leaders in the community. But here is the crossroad, that the success from now on and progress both in yourselves and in your pursuit of advancing science with intellectual honesty depends on you defining what you don't know and what we don't know, and having that courage to State that in the face of many of your colleagues believing the contrary, and including yourself. So can you do it? I believe that you can, and I do believe that this can be learnt as well, provided that you open your arms to your ignorance, and that when you hear contradictory things from speakers that are called professors, if you are prepared to embrace the contrasting statements that they make and not get bamboozled by them, you will help to forge the future. At the end of the day, trust your brain. I was told that by one of my mentors, Pierre Mounier, and it was told by many other people. Trust your brains. So let me turn to the skeleton after now talking about you guys. Bone is rope. Bone is type 1 collagen. It is very strong in extension, but if you compress it or bend it, it falls over onto itself. And so it becomes a useless material when you are born into a gravitational field, which requires stiffness. That is one of the most important properties of bone, to resist bending. And to resist bending, the skeleton becomes mineralized. It could use iron filings. It could use any sort of material, but it has chosen to use calcium hydroxyapatite, which is impregnated into the fibers of type 1 collagen. But there is always a price to pay in nature, that things have to be a little bit like the Humpty Dumpty, not Humpty Dumpty, like the three bears, that the bed has to be not too hard, but not too soft. And so there is a price to be paid that, and I hope the pointer works here, but as the mineral density, the impregnation of the collagen, type 1 collagen, is increased with more and more crystals of calcium hydroxyapatite, the bone becomes stiffer, but an increase of a given amount by 5-fold reduces bone toughness by 14-fold. Toughness is an awful word, but toughness is the ability of a bone to also deform a little bit, to take in the energy that is imposed upon it during bending and absorb it by changing length just a tiny amount at the nanoscopic level to absorb that energy. And so you have this contrasting situation. And so the right amount of mineral in this skin, in this type 1 collagen, depends on the animal, and it depends on the bone of that animal. And so, for example, the antlers of a deer, when two males are fighting to win a female deer, the antlers, the property needed is some toughness, some ability to bend. But if you are born as the ear ossicles, they have no strength whatsoever, but they have a very high mineral content. Why? Because the ossicles of the ear must vibrate. They should not burn any energy in deformation. All the energy needs to be faithfully transmitted as a vibration of a tuning fork to give the signals to the brain from the eardrum so that the words can be interpreted faithfully. And bone sits between the antlers of a deer and the bone of the ossicles, serving both to be very stiff, to facilitate movement, and to allow bone to serve as a lever. But in contrast also, some bones have this flexibility so that when you run and jump, that the energy can be absorbed. And here you can see, for example, the structure of the bone when it is made with lots of nothingness, with lots of void, it becomes like a spring so that it can deform and can maintain without breaking, can deform slightly, allowing this pole vaulter to jump over a building. And to allow this young fella here, it also needs to be stiff so that this weight can be lifted. And the arms and the legs of this handsome fellow are, of course, made to be very stiff. But bone is not a tube like a drinking straw. So that what is strange, and what I must say I don't really understand, is that if we look at cross-section to cross-section along the femoral neck here, the same amount of bone is used to build adjacent cross-sections, which are in fact different in shape and different in size. These are very round in the middle of the femoral neck. They are more elliptical where the femoral neck joins the femur, the long bone, the femur itself. What is different in the bone is that this same material is used and builds the femoral neck using differences not in mass, but in nothingness, in void. And that's why nature is so very clever, that it gets something for nothing. So here, where there are loads, great loads imposed, you have this oblique shape. The bone is built primarily as cortical or compact bone and less trabecular bone. Further along the femoral neck, the bone is more circular, and the cortex is more regular from point to point, and further up, most of the cortical thicknesses are fairly similar. Whereas here, the thickness is primarily inferior here, where most of the loading is taking place, at least in compression. And you can see the distribution curve of cortical thicknesses. They are different. There is no such thing as a cortical thickness. This is the thickness varies around the bone, and this is best described by the median cortical thickness rather than the mean cortical thickness. How this is made occurs during growth. So when we think of a bone increasing in size, it is not uniform. So for example, in the tibia here, much more bone is being deposited in the same unit of time, anteriorly and posteriorly, than medially or laterally. And by the selective point-by-point different regulation and different extents of periosteal apposition and endocortical, or the inside surface of the cortex lining the marrow cavity, the differences in the cellular activity at point to point around every single point around this perimeter, then from cross-section to cross-section along the bone, uses similar amounts of material, but positions that material differently in space. And that variance is determined by genetic factors that are, in growth at least, highly modifiable by exercise. But in adulthood, once the epiphyses have closed, we can do very little, if anything, to change the size or the shape of bone. Bone is even more complex. There is great heterogeneity. So, for example, the length of your radius, your forearm, is primarily formed by growth of the distal metaphysis here. So the length of the bone is moving mainly due to cellular activity distally, not proximally. This is not the same at the tibia, and it's not the same at the proximal and distal parts of the femur as well, which I don't have time to go through. Why is this important? It is important because the ends, the metaphyses of long bones, are the predominant site of what we call fragility fractures. I don't like to use the word osteoporotic fractures because most fractures in the community occur in people who do not have osteoporosis as defined by a T-score of minus 2.5 standard deviations. Remember that. It's very important. And what is happening here with growth is that there is endochondral apposition. Cartilage here, the trabeculae coming out of the growth plate, fused together to form the cortical layer here of the metaphyses. And the junction here, you can see these being adsorbed and coalescing. Why is that important? It's important because if there are abnormalities in growth of the distal end of long bones, then the trabeculae fail to coalesce. When they fail to coalesce, there is residual porosity formed that predisposes to a fall in children during this peripubertal period. It's not just that kids jump on swings and slides more often. It's a particular time when the rapidity of longitudinal growth is not matched by the formation of bone upon these trabeculae and leading those trabeculae to coalesce and to form in the periphery, to form that cortical shell together with the central trabecular bone. And this is why almost 30 to 50% of kids in the community have forearm fractures. The bone is fragile here because of this difference in growth pattern. When we look further along, this was just the metaphyses, a common site of fracture, the distal forearm, the ankle, the vertebra, which is basically two metaphyses stuck together without a diaphysis, and other bones as well. But the diaphysis grow, and in males and females, there is very little difference up to the time of puberty. And the position of the onset of puberty, I've drawn schematically here, occurring before, in females, before males, because we know females go to maturation sooner. The reason men are taller, males are taller than females, is not because they grow faster. It is because they have a longer pre-pubertal growth period. If you sit down with your husband and wife, you'll find that when you're sitting, your eyes are looking straight at each other. When you're standing, then on average, the male looks somewhat down to the female. And that's why, if you have a fight with your wife, you must have it sitting down at the breakfast table. Because if you have a fight and you have to be standing, sorry. If you're sitting and you're a male, you're going to lose that fight because she can see straight to you. Okay, so with growth and development, the larger bone size is due to continued growth on the periosteal surface in the male, but the growth which ceases sooner is followed by endocortical apposition on the inside. Why is that important? It's important because with delayed puberty, what fails to occur is this continued periosteal apposition in the male. So the male forms a smaller bone with a thinner cortex. In the female, shown here at the bottom, in the female, there is failure of endocortical apposition, but the bone is actually bigger. It's wider because the epiphyses don't close. So there is continued growth like in the male. But that longitudinal growth makes a bigger bone with a thinner cortex, so a larger medullary cavity. So the pathogenesis of bone fragility is surface-specific and sex-specific. These features are not captured when you measure BMD. BMD is a tricky shadow. I don't like BMD because it tells you nothing about the surface activity that I've been talking about up to this point. It gets worse. So if we just look now at body length, we know that the growth velocity slows down, then picks up rapidly at year 1. Then the body length continues on, growth velocity is stable, then kicks off again It kicks off at puberty, but the pattern is not in the legs. It is the spine. So at around puberty, the spinal growth accelerates, accounting for a large proportion of the increase in length at puberty. The legs don't accelerate. The legs at puberty get slower because the epiphyses close. So the velocity of growth goes down. Why is that important? Those of you who are interested in the pathogenesis of bone fragility originating in growth, I want you to think about this, that if you have a disease here, and I hope the point is working, if you have a disease in early puberty, in later puberty, in the peripubertal period, that disease will pick out the spine or the legs or both, depending on the rate of growth at the particular stage of growth that that particular individual is at. This is different in adulthood because all that matters in adulthood is the dose and the duration of the disease. That's not the same in kids. It's the dose and duration of disease and the maturational state of a kid. So let's look into the bone, and when we look into cortical bone, we see that it is made up of osteons, beautiful structures that confer strength to bone by the enormous heterogeneity of their bone structure, and that I'll talk about a little bit now. So here you see osteons. This is the Haversian canal running through the length of the long bone. These osteons have got concentric mineralized lamellae. They contain osteocytes in these little cavities, and they have a cement line. You see in the bottom image here, the cement line here. Here are the lamellae formed here, forming edges or forming what's called discontinuities. So that when you have a material that is sometimes of high density, low density, different compactness, when a crack occurs in that structure, it comes across edges, it comes across discontinuities that dissipate the energy needed to allow that crack to propagate. You can see a correlation between osteonal density, in other words, the number of osteons per unit volume of bone. Why? Because when a crack is traveling in the interosteonal or the interstitial bone, it gets blocked by the osteon with its cement line, lamellae, and the central fluid-filled canal. Why is that important? It's important because, as I'll discuss, I hope, that when we give drug therapy, that we change this microstructure, we change the nanostructure, and we change the edges, and we alter the heterogeneity of the structure to become more homogeneous. And if you have a homogeneous structure, it takes less energy for a crack like the Titanic to travel through the Atlantic Ocean, to open up that bone and result in complete fracture. All structures with age develop microdamage. Here you see it in the building. Here you see a crack traveling through cortical bone, and here you see these cracks. But bone is amazing. Bone has the osteocyte that Cliff so beautifully mentioned in his wonderful talk just now. The osteocytes connect with each other. They are the nervous system of the skeleton. And I hope to show you through this talk that if you think bone is a rock or a homogeneous moon, it isn't. It is as complex and as diverse as any organ system in the human body. These osteocytes connect with each other like the web of a spider. The spider knows the size of its dinner. It knows the location of its dinner, of a fly caught in its web, by the vibration, by the oscillations of the web, the location where the vibrations are coming from, and the magnitude of the sine wave produced by those oscillations. And this is the same sort of principle, that these osteocytes are sitting there everywhere in the skeleton. They are detecting changes. If there's a crack in bone, they are knocked off. Their connections are broken down. They undergo apoptosis. They communicate with other osteocytes that start the process of bone remodeling. That is the main purpose of this talk now. Bone remodeling begins by a little crack, not always, but for simplicity, there's a crack. It tears through the osteocytes here. The osteocytes communicate with flattened osteoblast cells. The vessels come in and they provide the precursors of the bone remodeling cells, the executive cells, the osteoclasts, the resorbing cells that will be recruited, shown here in yellow, and they dig away to remove this green crack that I've drawn here. And you can see the dead osteocytes signaling the location of the damage, and they signal in this process of bone resorption, which then removes damage and stops. How that all is regulated remains a mystery. How does it start? How far should it resorb? What are the signals that stop it? And how do we then move to the formation phase of this remodeling transaction, that a volume of bone is removed at one point, and then the volume of bone is replaced by osteoblast cells that deposit osteoid. Osteoid undergoes primary mineralization, and then it's called bone. That bone undergoes another process called secondary mineralization, which is simply the enlargement of the crystals of calcium hydroxyapatite deposited in primary mineralization. They enlarge, but the fiber doesn't change in size. The fiber stays the same, but it displaces water. The crystals enlarge, displacing water, making that fiber more brittle. That becomes important when we talk momentarily about drug therapy. The process of bone remodeling is surface specific. It occurs upon the periosteal or outer surface and three components of the endosteal or inner surface. The intracortical surface, formed by the lining of the Haversian canals and the Volkmann horizontal canals, the trabecular surface that connects with the Volkmann canals through these connections here, and the endocortical surface lining the marrow cavity. Together, these surfaces is where the action is. No surface, no bone remodeling. That becomes important. So, and this is the hard part of this talk, and so bear with me. Bone remodeling, that remodeling transaction of the removal of a volume of bone, its deposition, and the subsequent mineralization of that volume of material, osteoid, deposited, making it bone, are not instantaneous events. They have a different time course, and that time course makes it very difficult to think about bone remodeling. And so you may not get with it. I haven't got it right. I've been thinking about it for 35 years, and I still don't understand it, but I love it. So, because it's not instantaneous, you have events taking place in your now that were initiated before, and some initiated in your now. So, there are two deficits that result. If you are going to understand the loss of bone at menopause, the regain of bone density during drug therapy, and other features, you have to understand there are two deficits in the volume of bone mineralized matrix. One of them is fully reversible. That component is the result of the normal delay and slowness of the refilling phase of any given remodeling cycle at any given point. So you see osteoclasts digging away. They dig this hole in 3 weeks. There is what's called a reversal phase, or a lag phase, where we believe the precursor cells differentiate, forming the bone-forming cells. And Roland Baron, who will be at the meeting, and you should go up and meet him, one of the great minds in this field, has written extensively about this. Now, the reversal phase varies according to species, but it's about a week. Then the formation phase, with the deposition of osteoid depicted in white, takes about 3 months. You know, it's easy to knock down a building, takes 1 second, but it takes a lot longer to rebuild that building, and the bone is the same. So this material, the matrix is deposited, completely refilling the hole that has been dug. But before it's refilled, there is this deficit present. And this is the reversible or the transient remodeling space deficit. Why is it important? It is important because the main effects of the anti-resorptive drugs is on the reversible component. The reversible component is actually not the cause of bone fragility with aging. It's the second component, called the irreversible component of the deficit, produced by an imbalance, not a time lag, an imbalance between the volume of bone resorbed and the volume of bone deposited. So we refill the hole completely. There is a rapid phase of primary mineralization depicted by this gray balloon here. That is then followed by the much slower secondary phase. I'll try to come to explain why that's so important. So here are the crystals. I've tried to depict them as crystals enlarging very, very slowly over 2 years, maybe even longer, to complete the reversible component, so that the mineralization process is itself part of the reversible deficit in bone mineral. And it is ever present, because in your skeleton now, there are at different locations in your skeleton, there is time present, time past, and time future. And that's why I've shown you a picture here of the sky. It's the image I'm trying to get across to you, is that you look at these stars now, but many of those stars are dead. Many of those stars are much, much older and further away, but you're seeing the light of them this moment. But you'll never understand astronomy without understanding this time effect. And you will not understand bone remodeling, you will not understand the effects of drug therapy and menopause until you allow this complexity, and it is complex, to enter your thinking, and think about it and wake up in the middle of the night sweating, still trying to understand it. So when we look at a biopsy, we're looking at the past and now. So at some sites, there's a hole just been dug. At other sites, this hole was dug just like that one was, but it's now in its osteoid phase. So there's no longer here a deficit in matrix. The matrix has been replaced, but what the deficit is at this particular point is in its mineralization. Here's another one. At this particular point, this remodeling site, this star, was actually created earlier even, but it's at a later stage than the other sites here. And here's another site that was born maybe months to years earlier, but you're seeing it still undergoing secondary mineralization. So I hope that's clear. We go through menopause. What happens at menopause is 2 things. The first is, or one of them is, that the rate of bone remodeling increases. And that's the reason I've talked about the 2 deficits, the reversible and the irreversible deficit. The irreversible is coming. The reversible deficit is determined by the rate of bone remodeling. Now, if the only abnormality in menopause was an increase in the rate of bone remodeling, the number of remodeling sites, remodeling transactions being born at different parts of the skeleton, There would be a decrease in bone density, but then it would level off and it would stay flat, determined by the rate of that bone remodeling. In a person who has faster bone remodeling, that drop off with the red arrows would be even lower. If that was the only abnormality present, then that particular individual would be running along with more reversible deficits in the skeleton. And if we gave that woman a bisphosphonate, if we gave that woman hormone replacement therapy, that deficit would be completely replaced. But that's not the case. At menopause, there's another thing that happens. So I showed you before the resorption site, and it completely refilled. But it doesn't refill at midlife. There is a deficit produced because now something that we still don't understand has changed. That less bone, a smaller volume of bone is deposited in the resorption site with advancing age. And that's independent of menopause. It occurs in men and in women. But in women, that is compounded by estrogen deficiency, which alters the lifespan of the osteoclasts, making them live longer, digging a bigger hole, and it shortens the lifespan of the osteoblasts, so they put back less bone into the larger hole, causing perforation of the trabeculae and irreversible loss of bone. This deficit is the necessary and the sufficient cause of microstructural decay and permanent bone loss. This is osteoporosis. This is bone fragility. That's its pathogenesis, the negative bone balance. It is not reversible, as best we understand it, using anti-resorptive drugs. To rebuild the skeleton, we need anabolic therapy. And increasingly, if I may say, in the field, we're starting to discuss and recognize that the use of anabolic therapy may need to be first-line therapy, not the way that we've got it at present with the anti-resorptive drugs as first-line therapy and then occasional use of the bone-building drugs. I believe that has to change. So this slide here just shows you the slow decrease that with time, actually the resorption depth gets less. And you think, oh, that's really good. It's not necessarily good because the resorption depth of a cavity determines the anatomy, the geography of that osteon. And if you make osteons that are smaller and then you have less bone formation, you make a smaller osteon with a bigger hole in the middle, with fewer lamellae. And that may be deleterious to the skeleton. We don't know that yet because we haven't studied structure enough. So I hope that that's clear because I have no idea whether you hear me or see the slides or what's going on. All right, with menopause, and so we now have a state where you have high bone remodeling, lots of these sites, but now these sites all are leaving a negative balance that is doing two things. It's reducing the total bone volume of cortical and trabecular bone, and it is also disrupting the architecture of that diminished bone volume. The problem is, the challenge is that the reduction the deterioration in the microstructure is a power-function relationship between bone strength. So if you increase the porosity of a very compact structure like cortical bone, its strength goes down to the 7th power in some experiments. If you decay and increase the porosity of an already porous structure when you grew up, trabecular bone, then the reduction in strength or stiffness of that bone is to the 3rd power only. So what I'm saying by increasing porosity of trabecular bone, it's not that trabeculae get more holes, the trabeculae disappear, so the overall holes are bigger. It's a more porous trabecular bone. And so with menopause, because of this negative balance, each of these holes that have been dug, they refill, but they refill incompletely. So the loss of bone after menopause is not because you're resorbing bone. It wouldn't matter if you were resorbing bone if you refilled it completely, but you don't. So every time a remodeling event occurs, you are removing bone from the skeleton and you are disrupting that microarchitecture. And that's what we see here, that the loss of strength of trabecular bone by perforation for the same loss of density reduces the strength more than the thinning. Thinning occurs in men. This loss of structure occurs in women, and so you end up with a corrupted structure. In cortical bone, the intracortical remodeling causes thinning of the bone from the inside. It is cavitated from the inside. So this bone that you see in the bottom image here, this is not trabecular bone. This is highly trabecularized cortical bone. There are issues with this that are terribly important and could be discussed, I hope, at your meeting or through the meeting, that when you're measuring these structures, if you think this is the medullary compartment, the marrow cavity, then you are underestimating porosity in your patient. And that will underestimate that patient's risk. And look at the exponential relationship between the tiny increase, 5%, in porosity and the loss of stiffness in that bone. Whilst the inside surface, the endosteal envelope that I talked about, the trabecular, intracortical, and endocortical, are being resorbed, on the outside there is periosteal apposition taking place. So there's resorption taking place, but it's compensated for by periosteal apposition until after the menopause. And there's so little periosteal apposition that it's only by now that the actual strength of the bone starts to go down, because this bone now is being deteriorated in its mass or volume and its microstructure of that diminished amount of bone. When we treat with an anti-resorptive therapy, then think of the word anti-resorptive. So if you slow down bone resorption, so there's now here 6 or 8 cavities, but you're now slowing these down, then the rate of loss should decrease. But that doesn't happen. It's different. What happens is, what we all know, is that bone density goes up. Well, what does that really mean? The bone density goes up for 3 different reasons. That with treatment, you slow the number of holes being dug. And so there are fewer remodeling sites. That's the reversible component. The many holes that were dug after the menopause, because the remodeling rate is so high, refill, but do so incompletely. In addition, now because you've slowed down bone resorption and there are fewer sites removing matrix, that matrix remains in the bone longer. When it stays in the bone longer, it has more time to be secondarily mineralized, because the mineralization is such a slow process that it needs the bone to hang around. So this increase in bone density is the net result of fewer resorption cavities that are occurring in the placebo untreated group, and the incomplete refilling of the many more holes and the secondary mineralization of that bone. How can we possibly understand that if we do not study the material composition and the surface effects and the microstructure of the skeleton? And my view is that we can't. With continued long-term therapy, something happens, that now the bone remodeling, the BMD continues to increase. But this is virtually all secondary mineralization, because the rate of bone remodeling now is very, very slow. But still, that slowness of unbalanced remodeling is removing matrix. But the bone density goes up because the net bone density goes up because the diminishing total bone volume is increasing in its mineral density. Whilst we believe an increase in bone density makes bone stronger, it may not, because whilst there is continued slower remodeling using anti-resorptive therapy, you're still decaying the bone, but much more slowly, and the residual bone is undergoing more mineralization, becoming stiffer and stiffer, and may become brittle, and that, we believe, is one of the reasons we're seeing these atypical fractures occurring. And you see this as an example here in the 8-year study here of the bone density, continuing to increase in the hip here, continuing to increase at the spine. And we have the increased matrix density in the yellow compared to the green control group in trabecular and cortical bone. I want you to see here, I'll just move this, don't know if you can see this slide, that when we use weak anti-resorptives, we see this effect of anti-resorptive therapy on still allowing some of the bone loss to occur. In this study by Reed, with calcium supplementation, which reduces bone remodeling by only about 20%, and with raloxifene or with basodoxifene, that also are weak remodeling suppressants, you have this initial increase in the bone density, pointer should be working, increase in the bone density, but then the bone density goes down. It's in both of these papers, but never referred to by the authors. That's why I believe nothing. So despite continued compliance with therapy, the BMD is starting to go down. Why? Because it's also going down with the stronger anti-resorptives. But with these particular drugs, there is very little increase in the matrix mineral density, obscuring the slower decrease in bone volume with its mineral content due to the remodeling that is incompletely refilling the holes that were being dug after the menopause. I know it's hard. Can you hear me here still? If I'm still here. Can you hear me all right, John? Well, I'll go on. You can just, whatever. So in addition to secondary mineralization, there is cross-linking of the collagen with sugar. And we see this with a normal advancing age and with suppression of bone remodeling using various anti-resorptive drugs. We see a decrease in the work needed to break a bone. The bone is becoming more brittle. When we get older, this is what bone looks like. And the point I'm trying to make is that perhaps this bone can no longer be served with anti-resorptives, but we need to now move our generational perception to thinking, how do we reconstruct the skeleton? And we do that with 3 different anabolics that we've got available to us. One is primarily remodeling based, the other is primarily modeling based, and with some drugs it is both. And I'll show you some brief data on this, but I'm just not sure if I'm out of time or not. Remodeling-based bone formation is teriparatide.
Ego. We only have a few more minutes. Is it okay?
Okay.
Okay.
Yeah. Okay. So let me make a couple of quick points. So let me just say 3 different processes. With teriparatide, I know, John, you're going to talk about this. We can primarily, the teriparatide is remodeling based. Its bone formation is primarily in the existing resorption cavities and in cavities that the parathyroid hormone creates itself. And so you have deposition of bone upon trabeculae, perhaps on the inner surface of the bone, on the outer surface of the bone, but actually not within the bone. The 2 types of bone formation are the remodeling based, and you see the crenated surface here of previous bone resorption taking place. Whereas here, this is a smooth surface, and this is modeling based bone formation. With teriparatide, we reconstruct the skeleton, which you can see in this particular slide. But there is an increase in porosity that is temporary. And people regard this as being a bad thing. It's not necessarily a bad thing, because as we discussed before, these holes that are dug in cortical bone are the forerunner of new osteons. And those new osteons, when they have bone deposited in them, create new lamellae. They repopulate the osteons with osteocytes. They remove older mineralized bone and more glycated bone. They replace it with newer bone. So there are things, and this has been written about in a piecemeal nature, but we need to be putting this together. And this is why I believe that really we need to be turning to anabolic therapy. That is a good thing. We now have at least 2 trials showing better anti-fracture efficacy with bone building drugs than with the anti-resorptives. And I'm sure you're going to hear about it. So let me just move from that. And I'll move from that one. I'll leave that go, I think. Show you this one here. So before and after teriparatide, you see this shift in the mineral distribution curve towards a more heterogeneous bone mineralized bone matrix than this tightly peaked high mineral density that occurs after anti-resorptive therapy. One of the final slides here is the water content. I just draw your attention to it. Water is very important. In bone, there is vascular water, and then there is the tissue-bound water. These have an important role. Roloxifene influences that. I wanted to discuss abaloparatide, but I won't do that, and I'll really go to my last slide. My last slide is this. If you want the right answer, ask the right question. I believe that the questions we have in the field is, why do some younger people fracture more than others? Why do older people fracture more than younger? Why do some women fracture more than others? Some men more than others? Some women more than men? Some races more than others? You can use the bone density machine, guys, and you will see a shadow of the earth on the sun. But what I suggest to you is you don't take the blue pill, you take the red pill. And the red pill won't let you sleep at night, because you'll have to think about all the macro and microstructural qualities of bone. There's no such thing as bone quality. There are qualities of bone. What is the effect of growth, sex, race, aging, sex hormone deficiency, nutrition, exercise, diseases, therapies on the surfaces, the material composition, and the structure of bone, not just bone mineral density? If you stick to that, if you allow your brain to ask questions about what's the effect of exercise on the outer surface, the inner surface, the cortex, the porosity, the trabecular number, the matrix mineral density, you'll be asking the right questions, and you'll be amazed at how this will progress, not just science, but you. Thank you very much.